leather though. She looked at me like, bitch, he slide. I'm like, oh.
I would have been dying trying to hold my ass for real the whole time.
And I felt so bad because y'all know I'm already cheesy as hell unless I'm really pissed off. I was smiling the whole time. I said, this might not be the job for me. I smile too much.
All right.
I feel like I'd be scared though. I feel like I'd be like a spirit might hop on me.
Oh, you sound like my sister.
Because I believe in stuff like that. Like I believe in spirits. And
I do that too, but that's why I wear all my crystals like I do, because they stay the fuck away from me. All right.
So, today, welcome everyone. Chapter 54, Endodontics. This is page 820 in your modern dental assisting textbook. So you guys have been working on endo. Tell me, what is an endodontist? What do you guys know about endodontics, this field of study?
An endodontist is
What are they doing?
someone who performs root canal therapy.
Yes,
They
that is
manage the prevention, diagnosis, treatment of dental
periradicular tissues. Yeah, that's the answer I'm looking for. So one of the procedures they do is a root canal. So what does an endodontist do? Yeah, what you just said the second time. They're the diagnosing and treating of tissues around the pulp and those periradicular tissues, meaning all this stuff around the roots. Okay, so
all that white stuff?
Yeah, like where else, like bone stuff is, all that, everything there. That's peri meaning around, radicular relating to the root. So yeah, all right. So this is what I want you guys to know by the end of this lecture. Number one, define what it is. So we already kind of looked at this. You guys have an idea, but I'll put it back on the screen. You want to know causes of pulp disease. I'm going to just kind of look up here. Testing methods for pulpal treatment, like what are you going to do in the office? Pathology. So pathology is just like pulp in apical classifications. Remember, periradicular, apical, all this root stuff, because that's all endodontists do, is they're dealing with the pulp and the nerves and the root inside the tooth, right? So pathology is just like anything bad going on. So if there is, like if I have a tooth infection, then there's pathology of the teeth, right? Just something that shouldn't really be there. Also, procedures, non-surgical and surgical. So an example, like you said earlier, is a root canal. That's one of those procedures they use. And then today, I'm so happy you're in this lecture because tomorrow we're going over lab. We're going over all of that stuff back here. So,
all the stuff's on the yellow tray?
Well, excluding this part, but all of this nitty-gritty stuff.
Oh, okay.
So we're
like the anesthesia and all that.
The anesthesia, the how we, doing the actual root canal therapy. So today's lecture is really all on this stuff right here. And I'll just kind of leave it up because I probably will use it. All right, and then how to educate patients on pain expectations and outcomes. All right, so those are kind of what you should know by the end of this. And at the end of this lecture, I'm actually going to go back to the slide and we're going to make sure that we actually learned it. Okay. All right, let's keep moving. If I can get to it. There we go. So this is the first part we want to know, fundamentals of endodontics. Let's just continue our conversation. So what is endodontics? Well, this is basically it. The diagnosis and treatment of the pulp. Now, in your textbook, it does talk about a bunch of other things. I think it talks about other prognosis and treatment and all that stuff, but it's really just the diagnosis, treatment of the pulp. We know that. All right. This is a big idea, is that with endodontics, you just want to preserve as much natural tooth structure as you can. That's the main goal. Whenever possible, that's the main goal, to preserve the natural teeth. Right, dentists, we don't want to take out teeth. We don't want to drill into someone's mouth unethically if we don't have to, right? So that's the biggest thing. In endodontics, we have to think of this idea that we have to preserve as much tooth structure as we can. Now, there's an example. Back in the day, we'll learn about this, but back in the day, instead of filling up the canals with a flexible rubber material, they had to drill into the canals in a straight line and fill it up with these hard silver points.
I bet that hurt.
Yeah, and it's not used anymore. I always used to make a joke with the endodontist that I shadowed. I'm like, hey, are you gonna use a silver point? It's like, what? We haven't used silver points since the 70s. Why? Because of this. You just want to preserve as much tooth structure as you can. And if you're using gutta percha or that flexible rubber, you can flex. See how the canal curves a little bit? It's not in a straight line. But with a silver point, you have to make the canal a straight line. So you're getting rid of tooth structure unnecessarily.
I'm gonna have to watch a video of the root canal because I feel like I know what it is, just how like the word and stuff.
But yeah, we suggest that people do, because now with my model somewhere,
It makes a root canal in it.
well, it doesn't, but I could probably kind of drill into it and kind of show you. That's what I might do tomorrow in lab, like actually get my teeth, put it on the Typodont, and show everyone how to drill into it. So
So we be
people show
drilling
up.
into it or the dentist?
The dentist.
Oh, okay.
Assistants, the biggest thing, I was telling Sabrina about the assignment where you had to list every instrument and what it's used for. The reason why we do that is because for endodontics, the main part, like 90% of it, is what the assistant sets up.
Right.
Like you gotta make sure you have all of this. At Children's, like it took me 30 minutes in the morning trying to get all the equipment into my room set up. So I would have to come and work early if I knew I was doing an endo procedure, just because this is only like half of it
Right.
that you'll actually have. So we talked about this, so boom, that kind of answers what that is. The periverticular tissues. So that might already be in your notes, but that's just the supportive tissues around the periodontium. Again, I'm using all these perio. This just means the gums. Periodontium. That's why there's a periodontist.
I got tissues are the tissues that surround the root of the tooth. That's
Same-
the same thing.
That's just a little
Your word's
fancier.
just big.
Yeah. So the tissues and the tissues that surround the tooth, all of them are surrounded by this word called the periodontium, the whole thing. All right? So now we should know that endodontics, it's a specialized branch of dentistry involving the pulp. So if you ever work in an endodontic office, you're going to be dealing with the pulp quite a bit, all right? Also know that pulp is soft tissue. So like when you pull it out of the tooth, it kind of looks like a little thing of snot. It's actually white, right? Because when a tooth dies, well, there's no blood flow, it's necrotic, so you're just pulling out white goop. And if you see it, actually, you pull it out on these files. So you like stick this into the canal and then pull it out like a drain snake. Like if you've ever done that, like pulling out hair out of a sink, same type of thing. Yeah. Because you're pulling the tissue out of the tooth. So, all right. What is the role of the endodontist? Well, they have to go and do specialty training, right? So the specialty training is about 4 years. So number one, they have to go 4 years of dental school. After 4 years of college, so they have to go to a 4-year college program. You guys, we only need to do what, 9 months? 9 months. That's how long it is. So they got to do 4 years. Then on top of that, they got to do another 4 years in dental school if they can even get in, and then another 2 to 3 years in a specialty residency. Now, residency is the extra training component of like doctors. So, like you think of on the medical side, you graduate from medical school and get your degree, medical doctor. But can you do anything really? Like, can you be a surgeon? No, you have to go to residency and train to be a surgeon.
Just like Grey's Anatomy, they always have to red veins.
Exactly. So the same is true with endodontists. It's just not anything like Grey's Anatomy.
So basically, they're in school to learn how to do the surgical part. Since they did all the regular dental stuff, They just
They're
basically,
honing in
yeah,
on doing root canals and studying the pulp,
right.
right? The endodontist that I shadowed, I'm like, hey, so Dr. What was his name? Dr. Yanchak, Dr. Thomas Yanchak. He's probably retired now. But I'm like, so Dr. Yanchak, why did you want to be an endodontist? Why did you take 3 years of extra school? He's like, well, I just really like the pulp. I really like looking inside of teeth. So, which is true. It's really cool, actually, to look inside of the tooth. He had me look up, they have these big specialized microscopes. So if you look at an endodontist office or you watch someone do a root canal, they'll be sitting at a dental chair with this huge unit, this huge microscope. And they look through that so they can see microscopically inside the tooth. So they're the specialists. So if, like, you go to the general dentist for your cleaning, they might be able to do like some fillings, right? Some restorative work, but hey, you know, this cavity got down so bad that you have to go to the specialized endodontist. All right, the second part I want you to know is assessment of root canals and the diagnosis of it. Notice how these two things are in red. That might be an indication of something. So you need to know these two things. What are the causes of pulpal damage? There's two. The two main causes that's talked about in your textbook.
Is it up there already?
It's already up
there.
there.
The first one up there. Oh, they both up there. You just got to word
All right.
different.
So what? Give me an example then. What is some physical irritation without looking up here? What do you have written down?
I'm gonna look at my notes.
Yeah. So physical irritation. What do you have? Like, what are some
Physical irritation can be like if your gums are hurting, like if you have like if you have like an abscess on the side of your teeth.
That's an example of
I
this.
had one. Yep.
That's an example of this. Deep active caries, bacteria. Yeah. So that's a good example of physical irritation. Right? That pimple on your gums, that periapical abscess, it's putting pressure on your gums so it hurts because the fluid is building up inside.
It's trapped.
And it's trapped. It can't go anywhere. Right? It can't go anywhere. Except through your bloodstream and into your heart and your brain and the rest of your body. That's the key you want to let people know. Like, oh, there's been this pimple on my gums. Well, that's just a big breeding ground for bacteria and pus. And then sometimes, I have a textbook back there that you might have seen from 1836. They were like, hey, from 1836, they were like, hey, if there's that big thing on your gums, get a knife and just cut it open to drain the pressure, to get the bacteria out. But like,
Oh, when I had one, I popped it. But I didn't know I wasn't supposed to pop it until I looked up Google because it kept hurting. I'm like, I popped it, like, why I still hurting? And they said, you don't supposed to pop it.
Yeah, just because you don't want to spread all that bacteria around.
But can't you hit a nerve too, like if you pop it? Or no?
It's not likely. It's not likely. It's
the
more.
nerves at the bottom.
Yeah, but it's more superficial, like. Because remember, this isn't like necessarily a nerve. There are nerves in this canal,
right,
with other vessels and stuff like that. But this abscess, it wouldn't put pressure on the nerve until it does, right? Because it starts off as a little pimple of the gums, then it travels down, now you have a big lump on your neck, or it travels up and your eye is bloodshot and swollen, and then I get really freaked out that it might be starting to go up to your head or brain. Like that, I had a patient once at Children's where she walked in, and in the morning it was like 7 a.m. and she walked in, just a pimple on her gums, and we kept her up in the dental clinic for observation, and I was in charge of it, of going in and checking on her, and we handed off, and then I came back, and it was her entire face was swollen, her entire eye was swollen. And then I got freaked out, and then we had to admit her to the hospital overnight. IV antibiotics, observation with doctors and nurses, ENTs, the whole gang.
I mean, yeah, it is.
The whole gang, but she was at Children's. So the next day I was walking down on the concourse in the old cafeteria, and I saw her, and she was eating something, and she was all good. So it gets bad fast. All right. And then direct trauma. You probably wrote stuff about direct trauma. What's an example of direct trauma to the...
Like if you get punched in the face,
Boom.
you get hit by a football,
Yep.
so on and so on.
Yep. So I put up here sports injuries, like car crashes, obviously, people not wearing their seatbelt and then they get slammed in the steering wheel and then they, their face gets splattered and shattered and...
I can just imagine like when somebody get hit and they nose going up and they burn. Has
Yeah.
that a thing? Or no?
Say that again?
Like if you like in boxing or whatever, you get hit in your nose like this. Do that bone go up in your brain? Or it ain't possible?
Well,
I know that's off topic.
no, it's cartilage, so it's not going to be as strong as bone, especially right here.
Is
And
it shattered?
It would just shatter and or fall in on itself. Sure, there could be pieces if you really got like,
Hit hard?
but I think that's more like car crash territory or like
Yeah.
falling off your jet ski territory or
Mhm.
doing that stuff like, All right, let's keep on moving. Okay, so this just kind of discusses periradicular diagnosis. Again, I put up here in red that periradicular just means it extended into the tissues surrounding the root apex, right? But these are the three things you want to check, right? Is the pulp alive? So that's called pulp vitality. So you're checking to see is it vital or has the blood supply been lost, meaning necrotic. Like I said earlier, if you're taking out the like a necrotic pulp, it's going to be white. Now, if the pulp is still intact and the dentist is drilling, and then they see blood, well, that means the pulp is still there. That also means a lot more work for the dental assistant because they got into the canal when they weren't supposed to. That means I have to get out all kinds of other stuff to seal up the canal, and it's a pain. So you want to check to see if it's vital. Is it inflamed or irreversibly compromised? So what's that one word that we use for redness or inflammation that starts with an E? Erythema. Erythema. Wow, good. So that's what you're looking for, erythema of the periradicular tissues. And then you can kind of, sound really smart when you say that. But that's what it is. You want to check to see if it's red or inflamed. Okay, cool. And then has it broken through the apex and started to affect the bone? Remember, the majority of cavities start from the enamel. They're just sitting, the bacteria is sitting on top of here. And as the acid degenerates, you're going deeper and deeper and deeper and deeper until you're here. If you've got inflamed pulp, well, then it's going to travel down through the tip of the tooth, the hole at the tooth called the apical foramen, and then it surrounds that surrounding tissue. So has it gone through the root apex? And you can see it, like you can look at it on an x-ray. If you look at an x-ray and you're looking at the bottom of a root, you're going to notice it's going to look a lot darker, and we'll learn this in the next module about why it's going to look darker with x-rays. But it's going to look darker. You're going to see this dark circle around a root, and that's how you can check on the x-ray. All right?
Is the dark circle blood?
It's just,
Or just like the
I want to be careful how I say this, but it's a representation of how dense the tissue is. When I say tissue, I'm just talking about anything human body, right? So gums, teeth, bone, other stuff like that. So if there was bone there, and that's really dense, so then the x-ray can't get through it. Like,
it can't see it, so it just block it off.
It'll block it. Yeah, it'll block it off. That's kind of what I don't want to get too into it.
Right.
But yes, the same idea.
Right.
But if there's not as much bone there, more x-rays can go through it, and so it's not going to show up as white. It'll just show darker. So we'll leave it at that. But you got the idea. All right. These are the signs. So signs of pulpal disease. These are the questions you want to look for. These are the questions you want to either ask or just kind of observe. Is there spontaneous pain? So like, are they sleeping? Are they sleeping in the middle of the night and they wake up, oh man, my tooth hurts. Spontaneous pain, just without anything. typically worse when lying down just because the blood is, closer to your head. But speaking of blood, lingering pain. So that's something we'll check. So there's something I'm going to talk about in a minute called a hot and cold test, and it's going to be lingering. So you'll do the test, and it's going to take 5 or so seconds for the pain to go away after you caused pain. And that shouldn't really happen, right? So that's lingering pain. And then we call this functional pain, so when they're doing normal everyday activities with their mouth, like chewing, talking, biting down. We'll also check for tapping to see if it hurts if you tap on it. And then swelling, like what I was talking about. And this thing up here called a sinus tract, that just means there's a hole from the mouth into your sinus cavities. And then, is the tooth discolored? If the tooth is discolored, then that's the normal breakdown of the tissues, right? So you need all these things. These are signs of pulpal disease. You can't just say, oh, it's discolored, they have pulpal disease. You can't just say, oh, they have functional pain when I tap on it with my mirror, they have pulpal disease. No, you have to have all these things, right? Without stimulus. It just randomly hurts. It hurts for a long time. It hurts when you tap on it or when I chew. It looks like there's swelling or like that pimple on the gums, that abscess. And then, oh, is the tooth discolored from the rest? Look for that. Enamel, if you want to know, is colorless. It's clear crystal. The color of your teeth is determined by your dentin and your pulp. Right? You can't really stain enamel in the sense that I want to talk about, but the stain of your teeth, or the color of your tooth, is the color of your enamel. So all these whitening toothpastes, now that I'm going on a rant, but all these whitening toothpastes, if you're wondering, they go, when it says to go deep into the enamel, because that's what's actually causing it to become white. And then on the left-hand corner, you can't just rely on what the patient's saying. People are often really freaked out about, root canals or coming to the dentist, so they might be either actually in pain, ow, this actually really hurts, or they just want something done. So you got to make sure you have all these things that you're looking for. Okay, there's this thing that we do called a cold test. This is the most common thing we do in endodontics. And in Ohio, dental assistants are allowed to do this by themselves. So, if you want to do this in your office, I'd learn from this slide so you kind of know what it's about.
Do y'all got this stuff in here? You got the spray here?
We do not. It's the best smelling stuff in the world. It's a refrigerant, and it's called Endo Ice. So if you're ever working in an office, or you're just working in a dental emergency, and someone comes in, they crack their tooth, the first thing you're going to do is this thing called a cold test with Endo Ice.
It hurts.
Mm-hmm. It hurts if something's wrong. It doesn't if there's not.
Torturing the patient.
Yeah. So we use this. So what we do is we spray this. It just comes in a little spray can, kind of like keyboard duster. It looks like that.
Oh, like one of those when they got the little line.
Yeah.
Exactly, with the little tube, and you spray that on a little tiny cotton pellet on a pair of forceps.
And they put it on somebody's tooth. It's so wrong.
So, real quick, while you guys are finishing, I'm writing that down. Show you this. And these are your clinical responses down here. The first one's normal. So I grab my Endo Ice, I have the patient open up my Endo Ice on my cotton pellet. and then I tap it on the tooth. 1, and then I let go. And the patient's going to keep their hand up as long as they feel pain. And when they don't feel anything anymore, they're going to put their hand down. So, and that's how you know, that's how you count. Like if it's over a certain amount of time, like 5 seconds, this is what happens. That's severe lingering pain. It shouldn't hurt more than like 1 second. It should be like, ow, nothing else. It shouldn't tap on it and the patient's still holding up their hand, you know, in pain, like, you know, waiting for it to subside.
So it's just basically tested to see if the teeth hurt? Or tested to see, like, I'm confused. I don't know how confused, but I'm confused.
Okay, so
what do the Endodontics do?
Freeze. It's cold.
well, it's a severe cold sensation, and your teeth should be able to withstand it for like a second.
So y'all tested to see if the teeth is strong or not strong, basically? Okay.
And so the longer that they're still feeling the pain, the more and more we're heading towards irreversible pulpitis, meaning it's irreversible inflammation of the pulp. Itis always means inflammation. So pulpitis is pulp inflammation. Someone give me another itis. Gingivitis? There you go. Gingiva inflammation, gingivitis. So pulpitis is pulpal inflammation, but it's irreversible, meaning they have to get a root canal. We can't do anything to save the pulp at that point, right? And then again, necrosis, zero sensation. So what if I grab I spray it on, and then I tap it, and then I don't feel anything. Ooh, that's not good. The nerve's not there. The nerve died. There's no feeling, right?
It was numb.
Yeah, there's nothing there.
Nothing there. They ain't got a feeling at all.
And that's something that you got to make sure patients know with endo, like you're taking out the nerve. Now, most of the time, the nerve is the thing that's hurting them. So, you know, you want to do that, but also they will have no nerve anymore.
I got one question that just popped in my head. It's totally off topic. Do wisdom teeth have stem cells in them?
Do wisdom teeth have stem cells?
Yes.
Oh man.
I'm sorry, I'm just asking
I
because
used-
they said that they just found out that wisdom teeth have stem cells in it, but I feel like
I mean, I know that
you would know.
I know that they can regrow teeth with stem cells. I'm not sure where the stem cells are coming from. I don't know. I know they can. The thing I know about stem cells is they can regrow teeth. But I don't know where. I don't know where it's coming from. It could be from the. It could be from the wisdom teeth. Or it could be
That's
from
what I
like.
mean. It's like we just found out that you can get stem cells from teeth. Don't get your wisdom teeth pulled out.
Oh,
I
it's
still
one of
got
those
mine.
videos.
I still got one.
Oh, it's one of those.
Okay.
Okay. Well. Okay. Now I get the context.
Because if they heard
Number
it,
one. Okay. I get it now. Yes, there are. If that's okay. Now I get their argument.
Yeah.
Yes, there are. Those people though are very like funny about it because they're like, don't get your wisdom teeth out. The dentist is trying to take your teeth and like
Save other people.
save you.
Yeah.
And, like
But I mean, if it's hurting, take it out. Like you ain't gonna usually.
right and
Would you go grind it up?
what most of the time now in our evolution in human evolution, we don't need all those teeth. Our faces aren't big block. My wisdom teeth are trying to come in, but they're not. But there are stem cells in your wisdom teeth, but it's like either in the bud, like when they're developing, or like
Not
inside.
like he's already an adult and he's already like.
Yeah, there's no. If you have a impacted wisdom tooth, that's a very low quality argument to make that it has stem cells in it. But they do. But take out your, if it's hurting, don't keep it in there. All right. Heat testing, this is a little less common. Why? Because the cold test works really, really well. But it just depends on what you're looking for. Because maybe if you're thinking about a cavity, so let's zoom out of endodontics. We're no longer in a specialty practice. Now we're just in a normal, everyday family dentist. You walk in and you think that you have a cavity. or the dentist thinks that you have a cavity. They go in with their x-ray, they check an x-ray, they go in with their Explorer and they kind of feel around to see if it's soft or demineralized. But then they also might do the cold test. Why? Just to check to see if the pain stimulus is going through the enamel, through the dentin, into the nerve, in that case. Now you can do a heat test. Why would you want to do a heat test if a cold test tells you a lot? Well, the cold test for cavities, not, again, we're outside of endo. The cold test for cavities can let you know if the tooth can be saved. The tooth can be saved under cold. Once you get to hot, though, it can't. So a dentist might do a hot test. Now what they do is they get a Bunsen, one of those like, what do I call those, torches that I have back there? They get one of the torches, and then they grab a piece. Notice how tiny this is. That's how big they are, these gutta percha pieces. But they grab this, and they heat it up, and they touch it on the tooth. And again, same thing. Lingering is irreversible. A normal response will resolve quickly, just a normal tooth. And then here we go. I put this up here. If you're doing a heat test, isolate the tooth with a rubber dam and cotton rolls. And also when you're doing a heat test, put Vaseline on the tooth and the gums. Why? Because you don't want the gutta percha sticking to the teeth. Because you're melting a piece of plastic, basically, a piece of rubber. You don't want that sticking. It's not going to interfere with your reading, but always make sure to put some protection on there, on the tooth. All right. Pulp test is another testing method. So we did cold test with the endo ice. We did the heat test with our gutta percha. Now, in the modern day, we can do electric pulp testing. And I put a picture of what it looks like up here. Now, electric pulp testing gives a low current electrical stimulus to the tooth inside the pulp. Right? It's electrical stimuli. Now, when you're doing this, you have to dry the tooth completely with a 2x2 gauze, like one of these. That's a 2x2 gauze sponge. You'll need to have those when you're doing endodontics. Has to be completely dry. And you can use a small amount of toothpaste to conduct if you need to, like super small. Don't glob it on. Now, electric pulp testing, you got to know this. It's evaluating sensory nerves, not any type of blood supply. So it's checking if the nerve can feel something. And a little anatomy here. So you might be looking at this and you're like, okay, this looks like it's the end. If you would touch that to the tooth, it gives you a reading. Okay, cool. Okay, but what is this thing, right? Why are there a bunch of hooks? What is this for? Well, you got to hook that on to the patient. Yep, you got to hook that on, or the chair. Doesn't matter. Whatever your dentist does. All of my dentists did it differently, but they had to ground it some way.
Did you hear that? Yeah, it's the class next door. No way.
Making noise.
Yeah, she got the whole class.
So this is used when you're doing electric pulp testing. However you want to do it, you have to hook this onto something to ground it, to ground the electricity. And then here we go, wet teeth or saliva. That's going to conduct the electricity where you don't want it to go. It can give you a false reading. So always make sure to dry it with a 2x2. Super important. I like to dry teeth off anyway, because saliva just gets in the way of what I'm trying to look at, honestly. So I always have gauze, I always dry off the teeth, I always use my air water syringe. Make sure it's dry. Okay. Testing protocols.
So I go there and look. It's hella work for Thursday.
I looked at it too. It's like 6.
Well, it's a split session. So there's work for DA 307 and then the next class combined, and your test. So, but I'm glad everyone's here so I can make sure to get proficiencies in. Anyway, percussion and palpation. Percussion, you think of like a drums. You're tapping on stuff. When you're doing a percussion test, you're literally getting either a mouth mirror or the end of a forceps. But for demo, I'm going to use a mouth mirror. You go on and you tap the tooth with the end of this. That shouldn't hurt. If it does, might be something going on. Tapping with the mirror handle, you do it like this. You don't want to do it like that, but you want to get a nice blunt end. If you don't have this, grab a blunt end of your forceps. But that's your percussion. Now palpation, that's when you go along with your fingers and you're actually trying to feel if there's that pimple on the gums, right? If it's positive, you got apical inflammation. Now there's a periodontal assessment. Now we would be periodontal charting and the doctor would be doing the assessment, but you want to make sure and understand the gum health, right? So you want to make sure that if there's any deep pockets, you go in, probe around the gums, see what's going on. If it's super deep, you know that the gum has receded, the bone has receded. That's not good. All right. But the main thing you're going to see is you're going to want to feel around. Like as the assistant doing your initial assessment before they see the doctor, you can feel around. You're allowed to get a mouth mirror and tap on it, right? Are you going to be the one making the final diagnosis of what that tapping means? No. But can you still just say to the doctor, oh, I did the tapping test, it was sensitive, so then the doctor can make a better decision before they walk in? Because you're always going to have a conversation with them first about what you saw and what you talked about. All right. Next part, radiographs. Moving through it, x-rays. These are the ones you need. These are in your textbook too. It says these are right from your textbook. You need at least minimum of 4 x-rays taken for an endodontic procedure case. First one, it's basically this. You got a first one, the middle one. So first one is like, what does the tooth look like before we do anything? That's your diagnostic radiograph. Remember, radiograph is the fancy term for x-ray. In RCT, root canal therapy or root canal treatment. You need your diagnostic one just to see how things are going. Then you're going to take an x-ray of your working length. Your working length in endodontics is how long the canal is, right? Or from how long the tip of the tooth where your preparation was to the end of the apex of the tooth or the end of the roots. So you place those files in, you're going to measure the length, take a picture. Then the dentist, and you'll look through your procedure, and we'll do this tomorrow, but then they're going to fit in all these gutta-percha points. And you've read about gutta-percha. It's that rubber material that they put in the roots instead of having nerves there. So they fill it in. There's this thing called a master cone. That's your main one. So you guys can look at this, or you guys have seen it probably on the back counter, but these are super small, right? Now root canals can be bigger than this, but they come in super small and thicker. You would start off with a thicker one, fill up the majority of the canal, and then you would transition in putting more inside of it to kind of fill up the canal. You'll learn tomorrow why root canal sealer is so important, because the gutta-percha points don't fill all of the voids precisely, right? But once you've got your gutta-percha points in, you want to make sure they are a perfect fit before you go in and seal everything up. All right, so there are going to be 2 x-rays in the middle of the procedure. So you should set up the x-ray rings or your external localizing rings for an endodontic procedure. And the final one is immediately after and a recall. So I guess I could have put 5 up there, because post-op you want to do it right after everything's done, but then you also need to check it 6 months at their like hygiene appointment. So immediately after you seal it, and then 6 months just to keep an eye on things. You don't want bacteria going back into a canal, right? Some endodontists, they don't seal the canals properly, and then bacteria comes back into it. Oh, we just did all that work.
Right.
So you got to do the recall. You got to look at those x-rays, and you got to be very careful and be very keen on when you're looking at stuff, because you don't want to miss something at a recall appointment from something your office did. So it's good to know how to do a root canal properly, but also make sure you have all the x-rays so you can kind of see how it goes. And you can compare them. Like sometimes I'll compare an x-ray from what it looked like then versus now, and then we can see, oh, are there cavities coming back? Are there bone changes? We can make those distinctions with the recall. But just be aware that you'll be taking x-rays during a root canal. You wouldn't necessarily take an x-ray during a crown procedure. You would. One. A filling, no, you would just do one after. This one is you're taking x-rays kind of throughout. And that's kind of the thing with endodontists. They get really good at taking these periapical x-rays. The periapical, we keep thinking periapical. Well, that's a term of an x-ray that you'll learn. Why? Because you're getting around the apex of the tooth, or the tips of the roots. So. About halfway done. About halfway done.
Well, that's fine. You could go. I remember what it said.
Okay. Well, there's more slides. There's less slides than that because I have like these things. Now we're on pathology and diagnosis of endodontics. I'm glad this is big because I knew this chart that I put up here was going to be super small if I decided to put it.
Oh my God, I would have not.
Remember these? Remember on like cable or like satellite, the picture-in-picture?
Yes.
Yeah, that's kind of.
I would have not wrote that down. I would have been like, okay.
No, but this lecture was this is too important for you not to be able to see it. So
okay, Jack.
these are your primary pulpal diagnoses. You'll need to know what these are. You'll impress a doctor if you can be like, oh, I think it's normal. Oh, I think it's reversible pulpitis. I think it's symptomatic, irreversible, and then pulp necrosis. Like one day I walked up to Dr. Cassidy Boudreau. I was like, Dr. Cassidy, it seems to me, reversible pulpitis due to my endo tests and my palpation. She's like, and she walked in there, and she was like, yeah, Jackson, you're right. That's good. Yeah, make a dentist's day. Like you guys, we're all learning the same stuff. Just we focus on different aspects of it. So you can know this stuff. Know what these are. And then you got to know the clinical criteria. Do you really need to know what they do for a therapeutic action? Not really. Well, yeah, you kind of do. Now that I'm looking at it. Well, just for reversible, because there's going to be something in the next slide where I talk about a pulpotomy and a pulpectomy. And that's where they can kind of remove some of the pulp, but not all of the pulp. If it's reversible, it'll be mildly inflamed. This is kind of the first step. So this is normal. Everything's fine. Normal response, vital tissues, not painful. Cool. No treatment. Reversible. Mild inflammation. And then transient or non-lingering. So transient just means it's kind of sitting there. It's not lingering, but there was something there. Like maybe they had their hand up for like, I don't know, 2 to 3 seconds, not 5, but like maybe 2 to 3, putting their hand down. And what do you want to do with this? We'll just kind of remove it. Sometimes, and I've only seen this done twice in 6.5 years, that we've had to do where we take out just a little bit of the pulp because the bacteria was just like knocking on the door of the pulp, right? You don't want to leave bacteria in the pulp. You don't want to take, you're right, you don't want to take out the pulp, but literally, if you look at me, if I am the dentin, so I went through the enamel, through the dentin, outside of this door is the pulp. This is kind of how far the cavity has to get, and you would still take out only some of it. And that's a pulpectomy, and I'll show you what that is. There's pictures of it. And then all this stuff, symptomatic, irreversible, it's severe lingering thermal pain, like the hot and cold. Right? Severe is 5 more seconds. Sometimes we have to go in and intervene. Like it's sometimes really cold, and like they're like, hurting. You can go up there with your fingers and kind of warm it up for them. Like go and just kind of like, thermal friction, heat up the tooth again to help them out. You would do a root canal for symptomatic irreversible. Now, pulp necrosis, the last one up here, the pulp is dead. There's no vital tissue. Now you have a choice at this point. Do you want to do a root canal? Do you want to go through that procedure if your pulp is already that dead? Now, we got to think though. Like you got to think of the condition of the tooth. Like if it's completely blown out, then yeah, you would have to go ahead and extract it, like take it out and fill up the socket again with something. But if you can kind of get away with it, maybe a root canal. You got to know this: a root canal is accompanied with a crown. So I think next class we'll learn how to make temporary crowns on top of root canals. And this is next week. So next week we'll be making temporary crowns that go on top root canals, or really anything, where you have to kind of reshape and recontour the crown. All right, this is something I put up here that you might see. So asymptomatic irreversible pulpitis. So symptomatic irreversible means that's your severe lingering thermal pain. Asymptomatic means there's no pain at all. But the pulp is still not able to be healed. So sometimes the pulp is just, it's there, it's not fully necrosed, but it's so blown out that it's barely alive, it's barely breathing. You can't heal, no symptoms.
Almost here.
Okay.
I'm on the last macro roasted.
Because my happens.
Lecture days. You gotta love lecture day. Lab tomorrow should be fun. I'm excited for it.
Oh Lord. You excited? That means we should. What is it next?
We're just doing the root canal procedure with everyone.
Oh.
And it's gonna be me. I don't think Wadia is coming in tomorrow. So you guys are gonna see my lab run. I'll tell you that.
Is it nice?
It's nice.
We gonna be here till 10 o'clock.
It's not true. Maybe. Depends on how many people show up to do their lab.
But have the new people been showing up to do their labs?
They have.
That's good.
They have. We've really only just done setting up the syringe, and then, then we'll do oral surgery on Thursday, endo tomorrow, and then we'll start all of our prosthodontic stuff.
You think I should write down the additional kind of words, or it ain't gonna be on the test?
You could just write this word down. Or you could put up like a slash and put asymptomatic.
For all 4?
Well, just for this one.
For the system?
Yeah. There is a difference, but like you're not going to be the one. That's just kind of an additional thing. Okay. All right. Now your textbook, the test, and the RDA examination, they like to differentiate between pulpal diagnoses and apical diagnoses. So pulp is the pulp, right? This. But on the next slide, they want to talk about the apex. Where's the apex of the tooth?
At the top? On the side?
The apex. Where do all the nerves and roots come out of?
Oh, at the bottom?
At the bottom of the roots. Boom! Apical diagnoses.
Exactly how my teeth look like.
We've got a bunch of these here, like what they mean.
Oh, man.
You know all these too. By the end of this lecture, you can go and probably be an endodontist yourself. But I might put this lecture up.
That might need to be printed out. That's so great.
Yeah.
Not these old ones, but
Are there any of these in red? No.
2 of them.
Well, it's the apical abscess and the periodontitis. But we all know an apical abscess is that pimple on the gums, right? You guys see that tooth that's blown out on top? There's nothing there.
That's how my teeth look at Jackson. This is like I had that same mark because half of my tooth fell off, and I had it, but I don't get it no more.
Because the bacteria was crawling into the pulp, then coming out the side from here.
Right.
And then people are like, "What's this?" And they mess around with it, and then they get all freaked out because there's pus in their mouth. Okay, but I might post this.
I'm gonna just take a picture.
Yeah, you can take a picture, but I'd really just pay attention with the apical abscess and then the periodontitis.
Okay.
But you got to know there's a difference between pulp diagnosis and apical diagnosis. Right? I could say the pulp is necrosed with no apical diagnosis, or I could say the pulp is necrosed with an acute apical abscess. Different diagnoses because the conditions are very separate. Right? You have either bacteria just in your pulp, or oh no, the bacteria left your pulp and went outside the apex of your tooth and out into your gums right here. Right? So you got to differentiate those things. All right, now finishing up endodontic procedures. So what is the endodontic? We talked about endodontics. Talked about who an endodontist was. We talked about the diagnosis and treatment. How do we figure out what's going on? So once we figure that all out, this is the part we want to talk about. What are we actually doing? All right, pulp caps and pulpotomies. These are done mainly in pediatric dentistry. I've seen this done a lot. Now for a pulp cap, you've got direct pulp caps and you've got indirect pulp caps, right? So a direct pulp cap, now this word indicated, meaning you should do it if it's indicated, meaning you should do it when there's a small little pulp exposure, right? So that's the thing I was talking about earlier. If the dentist is drilling and they start seeing blood, small sterile pulp exposure, meaning it was done in the surgery. Like we did it in a sterile field. It didn't just like happen from bacteria degenerating the tooth. And then you would just put a biocompatible material and you would stimulate dentinal bridge formation. I put that in red because the pediatric dentist that told me about pulp caps, he wanted to make sure I knew that. And you would impress a lot of dentists if you're doing like a direct pulp cap or you talk about dentin bridge formation. You're like, how'd you learn about dentinal bridges? Jackson told me. If you want to look into dentin bridges and what they are, basically it's just remineralization between the top of the pulp chamber and the very bottom of the dentin, right? So if you think you punch a hole through it, you put a material back, that material is going to help regrow and close that hole. That's that dentinal bridge. It's coming together. Now indirect, when deep decay approaches the pulp. So what I need to circle up here is sterile pulp exposure. Indirect is where deep decay approaches the pulp. That's your key difference. Direct pulp cap means the dentist was looking at it directly and they decided to cap the pulp. Indirect means the dentist wasn't there when the pulp was exposed, but they still got to put something there to help fix it. That's your difference. The next one is a pulpotomy. Now, pulpotomies are where you take out the pulp chamber. That's it. You leave.
But like the sac of the pulp?
Yeah. So in a full root canal, why it's called root canal therapy is they're going through the pulp into the root canals. Pulpotomy. Otomy in surgery in medicine means to make a hole in something. I always think otomy is a big round O, like a hole. So a pulpotomy is they're just drilling into the pulp, taking out the big pulp chamber or that sac of the tooth, this part, and then they're just filling it up, hoping it'll stay vital. They're expecting that these down here haven't been affected by caries. Note how this is primarily used in kids' teeth or primary dentition and in emergencies. If you don't have time to do a full root canal, sure, you could do a pulpotomy, where it's kind of like a half root canal. And then a root canal is your full root canal where they go in, the pulp and the roots. You guys remember zinc oxide eugenol cement? Zinc oxide eugenol, ZOE cement?
Yeah, I remember that.
Yeah. So you would use that cement to fill up a pulpotomy. So if your doctor says, hey, we're doing a pulpotomy today on this primary tooth, what cement are you getting out? ZOE, yeah, good. So direct, when was the pulp exposed? When the dentist is looking at it. Indirect, when's the pulp exposed?
When you not there.
Not there. Direct versus indirect. Pulpotomy, are we taking out everything in the tooth? What are we just taking out?
Just the sac.
We want to say the pulp chamber.
Pulp chamber.
Yeah, good job.
Wait, so you said direct means the dentist is looking at it. Just looking at it. And then the other one he's not looking at it. And then the third one he's taking out the pulp chamber.
Those are my funny glasses. Meaning that they looked right at it. And this is what happens. This is where the assistant says, "Oh crap, really, dude?" When they hit the pulp. A direct pulp cap is where you're in the middle of a procedure, you weren't expecting something to happen, and then you hit the pulp, and then it turns into an endodontic procedure. So you could just be doing a normal filling, go too deep, and have to do a direct pulp cap. Does that make sense?
Mm-hmm.
You don't even have to be in endodontics. You know. So this can happen a lot. And then you got to know pulpotomies, just what's the word we use?
You said what? I'm sorry.
What are we just taking out? Pulpotomy? What's the word? The dental word?
The chamber?
Pulp chamber. Good.
Pulp chamber.
Good. Awesome. Otomy. Because the next thing we're going to look at is a pulpectomy. Okay? So a pulpectomy is kind of like a root canal, but it's just kind of like a baby root canal. You're doing the same stuff. You're taking out everything, but it's more temporary. So you're able to remove all your vital necrotic pulp, and then you can temporarily seal the canal with, like, I don't know, Cabot or another cement you decide to mix up. So pulpectomy is like, think of it like an emergency root canal. The pulpectomy is like an emergency root canal. You're not doing the full-blown, you know, taking all the x-rays, filling up with gutta-percha. You're just taking out all the diseased pulp, filling it up with a cement material until you can get back to it later. And then a root canal, you already know what this is, so you might not even need to write that. All right, so we know root canals, pulpectomy, pulpotomy, direct pulp cap, indirect pulp cap. Cool. Apicoectomy is where they go in, they open up your gums from the outside, they drill a hole to where your root is, and they take out the tip of your tooth. So I put up here, there is a surgical photograph on the next slide, so just be aware of that. There we go. Okay. So surgical endodontics, I think this is the last part that I wanted to talk about. Is really, this is the most surgical thing you're really going to get with endo. There was an endodontist that worked in the same unit as the oral surgeon I was working with, and oftentimes the oral surgeon and the endodontist would work together to do stuff like this. Sometimes the endodontist did it. Sometimes we did this in oral surgery just because they were referred over, right? Because I told you that's Dr. Janchak, that old guy. So if a root canal fails, or something happens, or you can't get access to the canals, well, then you have to go in the back way. So you can't go in through the top of the tooth. You have to go in the bottom, or the root. So you got to know this procedure. It's in red. An apicoectomy, this is just the surgical cutting or removal of a diseased root. So you take off the diseased root, usually with like a little drill, and then you fill it back up with a biocompatible material. Same material that you would really fill up with a apicoectomy. The pulpotomy. The pulpotomy. Same material, this retrograde filling, meaning we're coming in through the bottom, not the top. Retrograde. Or going the opposite direction of where you would expect. This is the stuff we used at Children's. This is MTA. It's called mineral trioxide aggregate. You don't need to know the full long thing. You just got to know about MTA. This is a bioinductive sealing material. So we might use this as root canal sealer too, right? You just come in from the bottom of the root. Why do you want to seal it up? Well, then you keep bacteria away from it. Right? You're blocking off any bacterial pathways by filling it up with this MTA, or mineral trioxide aggregate. And the name brand that we used was this Limelight Enhanced. It was this is bioactive light cure cavity liner. So that's why the cements class was super important, because you're using them, in everything. Liners, bases, cements, root canal sealers. It's just a cement. It's just a dental cement. That's why we learn about it. So an apicoectomy. Ecto means taking out part of something. Otomy means taking out the entire thing, that big hole, making a hole in something. Ectomy means taking out half of something. So apex apexectomy, taking out part of the apex of the tooth. That's where the word comes from, apicoectomy. Taking out part of the apex. And then retrofill, meaning you're going in with this material and you're filling up the root, okay? These are your instruments. You don't need to write these, but you want to look at these pictures because it's an Endodontic Explorer, a spoon, a spreader, and then a glick. All right, so these are actually on your tray. So the Endodontic Explorer, that's the long, oh, that's the spreader. This is the Endo Explorer, right? That's our Endo Explorer. Then we need our Endo Spoon Excavator, which looks like a little tiny spoon. That's our second one up there. Move down to the spreader. That's this weird looking instrument. Do you guys see that cool shape to it?
Mm-hmm.
How it kind of hooks back and comes back around? So that's our spreader. And then the next one I have up here is our glick. If we have it, oh, we do. So this is our paddle. Now it says it could either have a dual paddle or a plunger end. So ours has a paddle on one side, but then a plunger on the other. So it's two different instruments, just you're using either the glick side or the plunger side. So I just pulled up these up here. But you know these instruments, so I think we can move on. Just understand the Endodontic Explorer is long and stiff. The spoon is a little tiny spoon.
But are these the test questions? Like, but are they going to be asking like how?
You may not be asked on your test, but you'll need to know them for your lab.
Okay, I'm gonna take a picture.
You can take a picture of the, yeah. That's why I said today was important for lab, because I kind of going over the big ones. But tomorrow, you need to know, these are your big ones. You have to know that this is a spreader. Now you might be looking at the tray and you're like, well, Jackson, that looks like a spreader. Well, no, that's a plugger. This is the spreader. Notice the difference.
Do you hold them side by side? Oh.
The spreader has a pointy tip and it's longer.
Yeah.
Right? Pointed tip. See up there in red? And then the plugger end. Now this is a separate plugger. This one is a glick and a plugger. So I guess you really don't need this one, it's just kind of there to confuse you. So this is a plugger, that's a spreader, and this is a glick connected to a plugger. Okay. Glick number 1, mama number 5. Okay. Endodontic files. Again, this is taken straight from your textbook. Page numbers like 826 and 827. These are coming straight from them. But you got to know that in endodontics we've got different files. So we've got K files, which are up here. These are these colored little things. And then we've got broaches, and we've got reamers. We might have heatstrom files in the back, but you got to know what these files are. You want to know that K files and reamers look relatively the same. So I'd write that. A K file and a reamer are relatively the same. It's just how long the spirals are. Heatstrom files and bark broaches, those are different. They look different. They're used for different things. But you guys, I want you to look in your textbook because your textbook talks more specifically about what these are. Mm-hmm.
Yeah.
So these are your files. These are done with your hand. Like the endodontist goes in with their fingers and literally does this. Now we have them here, but we don't have the machine. But the next thing are rotary operated tools. So we've got two, the Gates Glidden and the piezo reamer. You connect these to an endodontic handpiece. Endodontic handpiece. you grab out another whole system that's separate. The Gates Glidden drill, it's football shaped, and it's used to go in and shape out the pulp. Okay? So this is kind of my memory trick to remember what a Gates Glidden is, or what it looks like. It has a football shape, and I kind of think of like opening up the gates to the football stadium. I don't know. But you got to know that the Gates Glidden drill is football shaped, right? And then your piezo reamers, they're used to do the same thing. They're a little longer and skinnier, so they can go deeper in the canals rather than just the chamber. So this is big and fat and football shaped to get into the pulp chamber, to smooth around the pulp chamber. The piezo reamers do the same thing, they're just shaped more straight. But just remember, you attach these to an endodontic, a specialty endodontic handpiece, not the ones on your back counter. You would actually grab it out and plug it in and connect everything, and you would have these two things that spin really, really fast to open up the preparation. So you got to know Gates Glidden tomorrow. I'll probably ask someone what shape is it. You guys know what shape is it?
Football.
Football shaped. Cool. Awesome. Then finally, we got to talk about materials and solutions. So we've got on this side our liquid medicaments: sodium hypochlorite, EDTA, chlorhexidine. Have you guys done your assignment on what is EDTA? Yeah. So you guys know what EDTA is. But I have a picture of all of them. So this is sodium hypochlorite from Henry Schein. EDTA is from the chemical company because you guys read about it. And then chlorhexidine gluconate. You'll see that in like an oral surgeon's office. They'll have you rinse around. So if someone has like gum disease, the dentist might prescribe chlorhexidine mouth rinse to actually, help kill some of that bacteria. So those are these three: your sodium hypochlorite or your bleach. You want to know this percentage, 0.5 to 5.25. That's the percentage in water. EDTA, you guys read about it. I'm not going to go too much into it, except that you got to know it removes the smear layer. Someone tell me what the smear layer is.
I don't think I'm there. Is it the work for today?
It's just general.
Like the smear layer, like the layer on your teeth, right?
Yeah. Good. Yes. So the smear layer is that gunky film that's on your teeth that's occluding your tubules.
Maybe like white.
Well, the smear layer is more microscopic. However, the bacteria in food and other things get trapped on it, so that's why it turns that gross, like white, brown, gritty color.
You said we need to write down just a percentage.
Yeah, the sodium hypo, the NaOCl, 0.5% to 5.25% NaOCl in distilled water. So you're not putting in like full-blown bleach. It's diluted, but you still got to be careful, right? And then this stuff, the gutta percha points, right? You guys will see it on the tray. This is what you fill the root canal with. And then I also have RC Prep, which is root canal preparation cream. Or root canal sealer. So you'll see those. All right. I think.
Is that the last slide?
Oh, the last one is patient communication. This is the last one. This is the last one. What do you need to tell your parents? Tell your parents. Tell your patients. So, look at this. This is so key. I'm even going to circle it. Angel says the same thing as I do, and I even wrote it down. So when you're at the dentist and you're the assistant, you're the one talking to them about the procedure. They're like, what procedure am I having? Well, you're having root canal therapy, and you go into it. And people are always freaked out about a root canal. They're like, oh, it's going to hurt so bad. You know, they're talking to their friends and family, and they're like, oh, I had a root canal. It hurts so bad, and it freaks people out. What hurt was what was going on before you had the procedure. That's why you had the root canal.
Right.
So it confuses people when their friends and family are talking like, oh man, it hurts so bad. Yeah, the bacteria and the infection in your mouth hurt very bad. The root canal, you didn't feel anything because you had this going on, right?
Which is
So-
local anesthetic, right?
Yeah, yes, the local anesthetic.
And then the tropical one come in the little box, the little circle thing. Okay.
Mm-hmm.
The topical. She keeps saying tropical.
Oh, it's tropical? Oh, yeah, because it go on top.
Yeah.
I've been over here week every time to say it.
I swear I thought it said tropical.
The
I think I
tropical
had it
one.
wrote
The
down
tropical anesthetic. We're going to the beach today.
I'm
For
telling you.
real.
Get that aesthetically good off the beach.
Yeah. So, what do you need to share? Post-op soreness is normal and manageable. Yeah, you're probably going to be sore because we took out half of your tooth and filled it up with rubber and cement. And yeah, or gold, or well, this guy, he's got a gold tooth, so, and he's missing one. He looks like a pirate. Anyway, treatment has high long-term success, so avoid these things. It literally says it straight from your textbook. You got to know this. You can't say it's going to work 100% of the time. You can't give them that. You can't say you'll feel zero discomfort. You might. You can't say the root canal will last forever. You can't say it's going to last forever. Most likely of the time, if they had a root canal, their oral hygiene is bad, and it's going to keep happening.
Yeah, because they.
So, just to let you know, don't say it's going to last forever, because it probably won't if they're getting one in the first place.
Oh, you talking
That's not
about
always
the
the-
ETA? That's today. Web assignment. I'm so behind Jack. I didn't
Oh,
even
you're-
look at my computer notes.
Well, then you'll learn a whole lot about ETA. Yeah. And then last one.
You like, I wouldn't lie to you. I told that to you.
I should have been doing this.
That shit took me 3 hours. That shit was
It's just I was just worried about my car over the weekend. I didn't care about nothing that going on with my car.
Did it just